fascinating disease in which the mortality has been reduced over the period of time, but the morbidity remains the same in the last few decades. The early onset meningitis, when the onset of symptom and clinical features occurs within the 3 days of life, while in late onset, the onset of features occur after the 3 days of life. In developed world, the incidence of culture-proven neonatal meningitis is estimated at about 0.3 per 1,000 live births. While in developing countries, the incidence of neonatal meningitis is much higher, which is at 0.8 to 6.1 per 1,000 live births. And if you look at the local data, the most vulnerable age among neonates, infants, childs, and adults is the neonatal age, in which about 50% of the cases in which there is occurrence of neonatal meningitis. It occurs more frequently in males, in preterm babies and low birth weight, and it usually occurs with sepsis while occasionally occurs in isolation. As you can see in the local data, males are predominantly involved. If you look at the weights, the low birth weight babies and the preterm babies are most commonly affected. If you talk about early versus late onset, you can look at the study done in Islamabad that shows that there is low incidence, which is 3.3% of neonatal meningitis among the neonates with early onset neonatal sepsis. While it is much common in late onset neonatal sepsis, as study done in Rawalpindi Military Hospital, in which it shows 34.5% of babies who develop meningitis in late onset sepsis. The predominant pathogens for early onset are, in developed world, group B Streptococcus, followed by E. coli, Listeria, and Streptococcus pneumoniae. While in developing world, group B is not that common, and gram-negative enteric organisms appear to account for the majority of early onset sepsis and meningitis. In late onset, Coagulase negative staph, followed by Staph aureus, E. coli, Klebsiella, Enterococcus, and Pseudomonas are more commonly involved. If you look at the data at Children's Hospital Lahore in 2019, in which the culture-proven neonatal sepsis shows significant incidence of neonatal meningitis, specifically in Pseudomonas, Klebsiella, E. coli, and cons. As neonatal bacterial meningitis most frequently results from bacteremia that occurs with neonatal sepsis, in which if there is higher the colony count, then there is higher the incidence and the risk of meningitis. However, it may also result from scalp lesion, particularly when developmental defects lead to communication between skin surface and subarachnoid space. Rarely, there is direct extension to the central nervous system from a contiguous otic focus, for example, in otitis media. If you talk about the pathogenesis, the bacteria which comes from the maternal source in early onset variety, and bacteria who comes from community or healthcare facility in late onset meningitis, then these bacterial invasion, after that they release the toxins and activate the hematopoietic system, followed by bacterial attachment to the WBC and endothelium, and there is transendothelial migration of the bacteria. After that, bacteria must have to cross the tight junction blood-brain barrier and then the loose junction blood CSF barrier. Then they release of pro-inflammatory cytokines and chemokines, activation of astrocytes, macrophages, and microglia, and then further release of cytokines and metalloproteinases, which ultimately cause the brain injury in neonatal meningitis. If we talk about the clinical features, the early signs are usually non-specific, and they are those of neonatal sepsis, like temperature instability, respiratory distress, apnea, lethargy, and jaundice. While specific signs may include seizures, vomiting, irritability, high-pitched cry, a bulging on full fontanelle, paradoxical irritability in which baby actually become more irritable while during consoling the baby, while knuckle rigidity and cranial nerve abnormalities occur in very, very rare situations. The gold standard for the diagnosis of neonatal bacterial meningitis is CSF analysis and its culture. And CSF should be obtained through lumbar puncture, and lumbar puncture should be done in all neonates with suspected meningitis, with suspected or proven late onset sepsis, and it should or may be done in early onset sepsis in which there is positive blood culture, in which whose clinical course or lab data strongly suggests the bacterial sepsis, or who initially worsen with antimicrobial therapy. An LP may be referred for any infants who is critically ill or likely to have cardiovascular or respiratory compromise from the procedure, when there is cellulitis overlying the LP sites, or when there is deranged bleeding profile like thrombocytopenia. What to do with the traumatic LP? Traumatic LP in a neonate is probability is common. Formula for corrected white cells are not significant and cannot be recommended. But this sample, this specimen can be useful for the culture, and in suspected cases, LP may be repeated after 48 hours. The repeat LP is debatable, but worth considering in babies who have not responded to the treatment after 48 hours of therapy, those who have seizures or continuous fever. But a lumbar puncture following completion of treatment in a clinically well baby is not indicated. A common problem is the parental counseling and getting the consent for a lumbar puncture. We should give a straightforward explanation of the urgency and essentialness of the procedure, as well as the details of the procedure itself. Maybe with the help of comparison with usual venipuncture is usually reassuring and should routinely be provided. But it should be done, lumbar puncture should be done by an expert who is doing regularly the lumbar puncture. While a junior person is doing, a senior person must be supervising. It may have major complication like LP-induced meningitis, epidural or subdural hematoma, acquired epidermoid tumor, damage to the adjacent structures, cerebral herniation, and the lateral recumbent position for LP can cause respiratory obstruction, hypoxemia, and cardiovascular instability. But fortunately, these complications are very, very rare. The values of CSF, which are suggestive of meningitis, are white cell count of more than 21, protein value of more than 100 milligrams per deciliter, and a glucose value of less than 70% of plasma glucose. If the baby's CSF shows these findings, it is suggestive of bacterial meningitis. CSF PSR had a higher yield of pathogens than even culture with prior antibiotic therapy. And CSF lactate levels, another very good marker with a high diagnostic accuracy, with high sensitivity and specificity, and it is able to detect bacterial meningitis. Cranial ultrasound should be performed early for the baseline data and then after 7 to 10 days. MRI is rarely indicated, but it should be or may be indicated in complicated and babies who are unresponsive to the treatment of meningitis. While we talk about the management, the supportive care, neonates bacterial meningitis should receive initial care in an intensive care unit. Management should focus on the cardiovascular instability or shock if there is present, appropriate respiratory support which is needed, careful fluid therapy, and please avoid both hypo and hypovolemia, prevention and management of hypoglycemia, control of seizures if seizures are there, and more importantly, the nutritional support. Preferably, babies should be offered the mother's own milk. Specific therapy is antimicrobial treatment, and the initial choice is empirical and based on age of onset, most likely pathogen, and sensitivity prevalent on the unit, followed by according to culture and sensitivity. We can suggest only in early onset ampicillin with an aminoglycoside with or without cefotaxime. And in late onset meningitis, to the above regime, you can add vancomycin in meningitic doses. It is difficult to generalize statement about the duration of antibiotic treatment. However, it is suggested to continue antibiotics for 2 weeks following CSF sterilization in gram-positive meningitis, while for 3 weeks following CSF sterilization in gram-negative meningitis, while longer duration of antimicrobial therapy is needed for complicated meningitis. Steroids have shown some benefit in individual studies, similarly IVIG, but these data are not sufficient to recommend its routine use in acute bacterial meningitis. Similarly, the growth factors, pentoxifylline and glycerol. So data is not sufficient to recommend these adjuvant therapy for neonatal bacterial meningitis. So risk factors which are involved in higher mortality rate and severe disability are low birth weight or premature babies, when there is history of symptoms for more than 24 hours before the admission, when there is leukopenia, which is less than 5,000, and neutropenia of less than 1,000. Seizures lasting longer than 72 hours, when there is incidence of coma, focal neurological deficit, when the babies require intubation for ventilatory support, need for inotropic support. In developed countries, the rate of mortality from bacterial meningitis among neonates has declined substantially from nearly 50% to recently to 10 to 15%. While in developing countries, the mortality rate is still much higher at about 40 to 60%. Approximately 20% of survivors have severe disability. Another 35% have mild to moderate disability. The babies who has risk factors can develop short-term neurological complications like cerebral edema, increased intracranial pressure, ventriculitis, cerebritis, hydrocephalus, brain abscess, cerebrovascular disease, which includes ischemic arterial stroke, subdural effusion, or hemorrhage. So neonates with bacterial meningitis should be monitored for these signs and complications throughout their treatment. If we talk about the long-term complication among the survivors, the mental retardation, learning disability, cerebral palsy, and behavioral problems have been reported as a long-term complication of bacterial meningitis in newborns. Seizures may recur in neonatal bacterial meningitis following the completion of therapy. There may be hydrocephalus, language disorders. Particularly important is hearing loss and impaired visual acuity. All infants with bacterial meningitis should be followed with long-term for development of neurological sequelae. And long-term follow-up for survival of neonatal meningitis includes the monitoring of hearing assessment, visual assessment, and developmental status. And babies should be referred for particular specialty if it is indicated. Preventive strategy applied during the antenatal, intrapartum, and early neonatal period will reduce the number of early onset diseases, like prevention of prematurity by detecting the early risk factors in mother, maternal antibiotic prophylaxis if mother has infection. At the time of delivery, we should adopt the safe and clean delivery techniques. And obviously, in postnatal period, especially we should promote early initiation of breastfeeding and kangaroo mother care, especially in preterm babies. Because the systemic reviews have shown significant reduction with these preventive strategies in the incidence of neonatal sepsis and bacterial meningitis. To prevent the nosocomial infection, the strategies that aim to limit the susceptibility to infection by enhancing the host defenses, interrupting the transmission of organism by healthcare workers, in which hand washing is of particular importance, while taking care of procedures, while we are doing the procedures, adopting safe preventive bundles and adhering to infection preventive and prevention and control policies in the hospital, and promote the judicious use of antimicrobial therapy. Obviously, we should promote the breastfeeding and kangaroo mother care in all newborns, especially in preterm babies. Prevention of complication is important because if we detect early signs and symptoms and start of empirical antibiotic, then we can prevent the complication of neonatal bacterial meningitis. So the key points: neonatal meningitis is the devastating disease which can lead to serious complications. Clinical manifestations are often non-specific, although the central nervous system signs like lethargy, seizures, vomiting, irritability may be present. The classic findings such as bulging of full fontanelle and knuckle rigidity are not very common. CSF culture is crucial in diagnosis because in certain cases, CSF cytology and protein are not very significant for bacterial meningitis. We should begin the empirical treatment as soon as possible, followed by specific drugs based on the results of culture and susceptibility testing. Treat gram-negative meningitis with 3 weeks of antimicrobial therapy, while gram-positive with 2 weeks of antibiotics. Corticosteroids currently are not recommended in the treatment of neonatal meningitis, and more focus should be given to prevention, because prevention is better than cure. Thank you very much. Any question or comments?
Thank you so much.
Professor.
Thank you so much, sir. It was a very wonderful presentation. So should we start question and answer session?
Yeah. Okay. So
I have a question.
we will do that. Yeah, I will do that. No problem. Sikandar, there are a few questions are very relative and we have to discuss. So first question is, what is the abnormal WBC count you consider in CSF? 30, 25, 20?
So I have mentioned that because in most of the studies, the normal values of CSF usually at the 95th centiles are 19. So in most of the studies and in even our reference book, the recommended WBC count, which is 21, should be taken as abnormal for meningitis.
But there are people who are taking 30 and above. Yeah.
No,
sir,
I agree. All the data which has been published shows a maximum level of about 20, 21. So that is the upper limit of normal. Anything above 20, 21 would be considered abnormal and should be considered meningitis. Going up to 30 is far too much, but the evidence there is at 20. And I think in your hot topics, Junaid, Pauline also had a cutoff at 20.
Yes. So the one additional question, that if we suspect meningitis, Sikandar, in a premature baby who are in the NICU, is there any difference of cutoff value, or you will consider the same for CSF WBC count?
So in early days of preterm babies, there is reported more WBC count which are come into the normal range. But the cutoff values for all babies to suspect the meningitis is 21.
Okay.
Because in preterm babies, even the clinical features are even more non-specific.
Okay.
Professor Khalid can add into this.
Yeah. So, sir, we consider for premature babies the same number, 20 and above.
I think so.
Okay. So now the one very interesting question: why are the meningeal signs are absent in neonates? I think Saeed, you should answer this.
But again, the brain is not fully formed and immature, so that's why in newborns the meningeal signs are not, as we found in the pediatric patients. So comparatively in neonates, it's not looks like that. So that is actually the reason of meningeal signs.
Sikandar, you agree?
Sir, आप बताइए सर, आप expert.
So you agree or not? You are doing today meningitis. I am not. Because the maturity of the meninges is one of the things, but it is mature, otherwise all the newborn babies can have the meningitis, So the blood-brain barrier is mature, and this thing, the meninges itself is mature enough. The only thing which is not mature is because their newborn babies are more flexible, so the stretch of and the pain due to that stretch reflexly we cannot feel in the babies, because babies' bones and everything are very relaxed and we cannot feel it. But this is my understanding also. Anybody want to add up more? Be my guest. Okay, so the next question is lumbar puncture with ordinary needle versus LP needle.
It should
Anybody?
be done with proper LP needle.
Okay, but many times it's not available, especially in our country. So what do you think if we will do with the butterfly?
It should be done, and it should be, sir.
Yeah, go ahead, sir. Talal.
Let Sikandar answer. That's fine.
नहीं सर आप बताएं सर प्लीज.
वो डर्मोइड करता है अगर स्किन पीस चला जाता है अंदर, बट रेयरली है. बट हमारे मुल्क में तो जाहिर बात है कॉस्ट इफेक्टिवनेस बहुत अरसे से हमेशा से आर्म स्विंग नीडल से हो रही है, बट रिकमेंडेशन ये नहीं है बिकॉज यू कैन कॉज डर्मोइड देयर.
श्योर.
बट मजबूरी है, हम करते हैं और कर रहे हैं हमेशा से.
नहीं सर, वो कॉस्ट
कॉस्ट
इफेक्टिवनेस के अलावा इजी जो है वो यहाँ पे बटरफ्लाई से भी होती है. तो मैनी पीपल आर डूइंग इन बटरफ्लाई, इवन इन स्टेट्स दे आर डूइंग बटरफ्लाई.
लेकिन थ्योरेटिकली जुनेद, इट्स अगर आपके पास ट्रोकार एंड कैनुला एलपी नीडल अवेलेबल है उससे करना चाहिए, बिकॉज यू आर इंक्रीजिंग द रिस्क of dermoid formation and implantation of skin.
And also the tract formation.
Absolutely.
So, yeah, the recommendation is that, but the people...
I think we can understand that कि limitation है सारी चीजें, लेकिन जो पढ़ाने के लिए और जो सही तरीका है वो ये है, लेकिन resources अगर नहीं है तो नहीं है, तो क्या किया जाए?
Sure. Okay, so another question anybody can answer: how much platelets count should be required for LP?
क्या सवाल था? Sorry, I didn't hear that.
Sir, LP करने के लिए कितने platelet counts होने चाहिए? To me, 50 and above is more than enough, but if you can add or...
देखिए, most procedures, traumatic procedures, should not be done if the platelets are less than 50,000. That's the standard practice. That's the
standard practice. Okay. Now, there's another question about, is there a persistent CSF positive? Can we give rifampin in addition to vancomycin? Oh, this is very hard. I don't know the answer. अगर persistent CSF positive आ रहा है, so we have to check the sensitivity and we have to know the bug, na? To me, Sikandar, Talal, or sir, if you can add to this question.
I could not find any reference for use of rifampicin for bacterial meningitis.
Sure. Okay. Okay. Now the problem is what you told Sikandar is the traumatic.
एक मिनट जुनेद, ये जो है अगर CSF persistent आ रहा है तो उसकी दो वजह हो सकती है, या तो आपने सही एंटीबायोटिक नहीं दी या सही डोसेज में नहीं दी, which antibiotic which has not gone into the CSF, you have not achieved the MIC or MBC in the CSF. So that is the reason. Rather than adding another antibiotic, you should check what the MIC or MBC of that particular antibiotic which you're giving in the CSF is before you add antibiotics.
और फिर ये कि वो
वेंट्रिकुलाइटिस भी हो जाता है सर, या वेंट्रिकुलाइटिस हो जाए फिर भी बड़ा मुश्किल होता है MIC अचीव करना, और डोज नीड्स टू बी एडजस्टेड.
नहीं देखिए, लेकिन तलाल जो सही बात है वो सही बात है. अगर मुश्किल है तो मुश्किल है. आई कैन अंडरस्टैंड दैट, बट आप दूसरी एंटीबायोटिक ऐड करेंगे, फिर तीसरी एंटीबायोटिक ऐड करेंगे, यू गो इनटू अ विशियस साइकिल.
Absolutely, rifampicin is not the answer. No, it's not the answer.
Okay, so so the other question था कि अगर traumatic LP है, what is the best approach to decide about WBC count? To me, you shouldn't decide about the WBC count in the traumatic tab. Let's say what Professor Haq, Talal, and Sikandar said about that.
सर जितनी भी स्टडीज हैं उन्होंने ये शो किया है कि ये जो रेशियोज हम लेते हैं फॉर आरबीसी टू डब्ल्यूबीसी, these are not significant.
जी
So,
बिल्कुल
but this sample, if it is a true traumatic LP in which there is CSF, then it can be sent for cultures.
अच्छा, that's we do only.
अच्छा, इसका ये बिल्कुल सही कह रहे हैं। मैंने भी बहुत मेनिंजाइटिस के टॉक पर आपको बताया था ये कि CSF ब्लड स्टेन CSF is not cell count is not. Why is it not countable? The question to Sikandar is, why should we not use this formula?
Because studies are not have shown very low specificity in these formulas.
Sikandar, what is the basis of that? Why have they not shown that?
Because the clot attracts lots of inflammatory markers into it, so it's very difficult then to
Absolutely. It's the clot. It traps the white cells, and so unless you drew cross section of clots, you cannot determine the exact white cell count.
Sure. So I will stop here. The question was come on the question and answer. Dr. Naila, Dr. Naila want to ask some question. Yes, go ahead, Naila. Walaikum assalam.
सिकंदर, बहुत अच्छी प्रेजेंटेशन थी, आपने जल्दी से सब खत्म कर दिया। मुझे ये पूछना है कि जैसे अमाइनो ग्लाइकोसाइड हमारी फर्स्ट लाइन है और हमें ग्राम पॉजिटिव में भी 14 डेज देनी है, तो वैसे यूजुअली हम जब दे रहे होते हैं हम कहते हैं 5 डेज पे स्टॉप कर दें, तो मेनिंजाइटिस में फिर क्या बीच में थोड़ा स्टॉप करना चाहिए या कंटिन्यू करनी चाहिए?
Answer is if we have to prolong the duration of amino glycoside, first we should look into the renal function test, and then we can extend into 10 or 14 days.
Okay. Talal, yes, go ahead.
नहीं, मैंने तो दो और सवाल करने हैं, डिस्कशन करनी है। एक तो ये कि पहले इसका जवाब दे ले फिर करें। हाँ, पहले इसका मुझे नहीं पता।
सर, इस सवाल का क्या जवाब है?
We should not stop in the middle. We should continue for 14 days.
अभी प्रॉब्लम ये है कि है ना, वहां पे लेवल्स होते हैं, नहीं होते, और फिर किडनी फंक्शंस. सो व्हाट you all of you think about to give ampicillin cefotaxime instead of or cefuroxime instead of aminoglycoside in proven meningitis?
So, in our most of the studies, still the sensitivity of aminoglycoside is very high. So we usually include aminoglycoside in the treatment of neonatal sepsis and meningitis.
Okay. जी, तलाल, you are asking some questions.
Questions here, sir. Sir Junaid.
मैंने दो चीजें, और एक तो
अच्छा, एक मिनट तलाल, सईद कुछ कहना चाह रहे हैं, मैं सईद को ओवरराइड कर रहा हूँ, सॉरी सईद.
नहीं सर, नो प्रॉब्लम सर. एक्चुअली फ्यू मोर क्वेश्चंस जो थे इसमें क्वेश्चन आंसर चैट बॉक्स में, तो वो थोड़े से मिस हो गए, तो अगर आप इजाजत दें तो वो कुछ
अभी एक, हाँ चले, नो प्रॉब्लम, पूछ लो.
अच्छा, तो सर one more question from Dr. Ayaz Hussain side. Okay, what are the proven side effect of LP which we should tell during taking consent? So मैं दोबारा कह रहा हूँ, what are the proven side effect of the lumbar puncture which we should tell during taking consent?
मैं पैसे दे देती हूँ, आपके पास है ना 1000 का, अभी आप कह रहे थे है.
अच्छा, उसमें ऐसा है कि जो साइड इफेक्ट्स ऑफ लंबर पंक्चर है, वो अगर हमने आमतौर पे, मैंने अभी जिस तरह मेंशन भी किया था, there are certain side effects which are related to lumbar puncture, but these are very very rare. So for taking the consent from the parents, usually it is not necessary to take to tell them the side effects of the which is very, very rare. So I don't think if you tell the side effects of the lumbar puncture, you will not getting the consent, because it is very, very rare. You can ask the effectiveness and you can ask the essentialness of the test to get the LP done.
राइट तो सर इन सिंपल अगर के हम फर्ज करें, अगर कोई हम लंबर पंक्चर करने जा रहे हैं तो ड्यूरिंग टेकिंग द कंसेंट तो हम सिंपली हम उनको फिर वो जो साइड इफेक्ट्स हैं वो हम बताएं ही नहीं। अगर हम, क्योंकि जब भी हम जो है ना, ये रिसेंटली डिस्कशन भी हुई थी शायद ग्रुप पे, तो किसी ने पूछा भी था, तो जब हम पेरेंट्स को ये चीज़ बताते हैं कि इसका ये भी साइड इफेक्ट जो कि वेरी रेयर है, तो पेरेंट्स डेफिनेटली हम सब जो है ना इन चीज़ों से कैम अक्रॉस के वो डर जाते हैं। तो ये ज़रूरी है कि हम फिर भी उनको ये बताएं जो कि साइड इफ़ेक्ट्स बिल्कुल रेयर हैं।
यही मैं आपसे अर्ज कर रहा हूँ कि एक्चुअली ये वाले जो रेयर साइड इफेक्ट्स हैं उनको बताने की जरूरत नहीं है टू टेकिंग द कंसेंट एक्चुअली। और आपने इसको कंपेयर अगर करें कि अगर आप वेनिपेंचर करते हैं, आईवी लाइंस जब ऑब्टेन करते हैं, तो आप यूजुअली उनको ये नहीं बताते कि उसमें जो है ना उसके क्या साइड इफेक्ट्स, बिकॉज इट इज एसेंशियल टू डू दैट, वी हैव टू डू।
राइट सर, राइट
In my
सर।
opinion.
राइट सर। सर वन मोर क्वेश्चन के हाउ मच वॉल्यूम शुड बी कलेक्टेड फॉर CSF?
Usually 1 ml each for cytology, biochemistry, and 1 for
culture.
culture.
Right, sir. So another question is in which percentage of proven meningitis CSF CS is positive?
Proven meningitis CSF.
In which percentage of proven meningitis CSF CS is positive? Some I think ये पूछना चाहते हैं डॉक्टर एजाज के, आई थिंक डॉक्टर एजाज हमारे साथ भी हैं, अगर वो माइक ऑन कर दें तो वो एक मिनट सर, मैं इनसे डॉक्टर एजाज, कैन यू हेयर मी?
मैं इसका आंसर ये कर सकता हूँ, जो हमारी चिल्ड्रन हॉस्पिटल की स्टडी है उसमें जो पॉजिटिव मेनिंजाइटिस के केसेस थे उनमें 45% ऑफ द कल्चर्स बिकेम पॉजिटिव।
राइट सर, 45%। राइट सर,
इन आवर स्टडी। यस,
ठीक सर। सर वन मोर क्वेश्चन, when we say or label partially treated meningitis,
इसमें I will request Professor Haq to comment on.
Sure, sir.
Well, partially treated meningitis is when the cell count is up and the protein level is up, but there is no culture negative. It's culture negative.
Right, sir. So it means protein will be raised and culture will be negative. It's simple. And
yes.
cell count will be
high.
High.
Maybe
right.
high. Maybe high. Yes.
Maybe high. Right, sir. So over to you, sir, Professor Talal Sahab. Sir, please continue.
सर दो तीन चीजें पूछनी थी डॉक्टर हक से भी और बाकियों से भी। एक तो ये कि
सिकंदर से पूछो, लेट्स लीव इट विद द प्रेजेंटर।
सिकंदर से बिल्कुल बिल्कुल। हर्पेटिक मेनिंजाइटिस अब सोचना चाहिए, हमारे यहाँ हिस्ट्री ऑफ जेनिटल वार्ड्स वगैरह जरा मुश्किल होती है और वैसे भी नहीं होती। what we do is, I don't know whether we do it right or wrong, but we consider अगर unexplained ALT ज्यादा है और वायरल पिक्चर है CSF में तो एक्लोवा एसाइक्लोवेर देनी चाहिए और कितने अरसे के लिए देनी चाहिए। PCR नहीं होता, फैसिलिटीज नहीं है। So one thing, and the other thing is fungal meningitis. We've seen quite a lot. What we have seen is that amphotericin is the drug of choice, 3 to 6 weeks देनी चाहिए, but liposomal, I recently came across this fact, but मुझे भी इतना नहीं पता था, जो liposomal amphotericin है वो blood brain barrier बहुत कम क्रॉस करती है। सो अगर आपने देनी है तो फिर आपको amphotericin देनी पड़ती है जो कि नेफ्रोटॉक्सिक भी बहुत है दूसरी वाली। So, Sikandar and Dr. Hak's take on these two things.
Sir. whenever if you talk about the herpes simplex, whenever there is RBC count and culture is negative in CSF, then we should think about the viral meningitis, and use and start of a clova is mandatory. And usually it is given for about 2 weeks. Regarding the fungal meningitis, I think Professor, because our experience is very limited, so Professor Hayat can comment on it.
जुनेद आप करेंगे इसको या मैं आंसर करूं? आप करेंगे?
Sir, Junaid is actually busy with another meeting, so he's not available right now.
Okay, so let's take herpes meningitis. Herpes meningitis is just like any other viral meningitis. You will have other, जो आपने तलाल ने बताया, if the ALTs and other things are raised and the cell count is raised, but the culture is negative, then you should consider herpes meningitis, and you should start acyclovir. And as very rightly said by Sikandar, minimum is about 2 weeks. As far as fungal meningitis is concerned, if you're absolutely sure it is fungal meningitis, then amphotericin, despite its poor entrance into the CSF, should be added.
ठीक सर दो तरह की आती है पाकिस्तान में, एक लिपोसोमल आती है और एक दूसरी आती है। जो लिपोसोमल है वो ब्लड ब्रेन बैरियर क्रॉस नहीं करती इतनी, सो आई सजेस्ट लोगों को कि अगर जरूरत है तो फिर दूसरी वाली दी जाए, नॉन लिपोसोमल एम्फोटेरिसिन।
जी, लाइपोसोमल इसलिए नहीं क्रॉस करती कि वो फैट ग्लोब्यूल्स में ट्रैप हो जाते।
जी सर बिल्कुल, और ज्यादा प्रिपरेशन वो आ रही है, दूसरी आपको ढूंढनी पड़ती है, बिकॉज हमारे यहाँ आपको होता है फैंसी प्रिपरेशंस आर मच मोर रेडली अवेलेबल इन द मार्केट।
Sikandar, it's a wonderful presentation. I enjoyed it very much. Very good.
So here is one more question from our colleague. What is effectiveness of CSF biofire in the diagnosis of meningitis?
क्या क्वेश्चन है सही? मैंने नहीं समझा।
So I think Dr. Ejaz is with us. Dr. Ejaz, can you hear me?
Yes, sir, I can hear you.
GT, please, you can ask the question now.
Biofire, this is the investigation which diagnose some antigens of some viruses and bacteria. So this
Your voice is not clear, Dr. Ejaz.
I am talking about CSF biofire.
CSF biofire. Sir, he's asking what is effectiveness of CSF biofire in the diagnosis.
What is biofire?
CSF what? क्या चीज CSF?
Biofire. नहीं कोई चीज है. But what is biofire?
Biofire actually is a panel test for 14 common bacterial, viral, and fungal pathogens.
I do not know. I do not know.
I myself don't know about this.
मैंने पहले ये नहीं सुना कभी, मुझे नहीं पता।
Sir, Sajjad Rahman
why we have to do? But why we have to do that much test when we have limitations of many things? I mean, anyway, go ahead, Saeed.
Sajjad is with us, sir. Sir, can you hear me?
Hello, yes, please.
Ji, sir, welcome, sir.
Yeah, thank you very much. I'm sorry if I was a little bit late because of evening prayers and timings. I just wanted to know about the fungal meningitis. How are the people treating it? Do you give one antifungal or two antifungals? And for how long do you give it?
Sir, in our setup, actually fungal meningitis, we have fungal sepsis, but we could not very rare experience of fungal meningitis. But if there is fungal infection like fungal neonatal sepsis, then the duration of treatment, we usually start with one antifungal therapy and continue for 2 to 3 weeks. Sometimes it is required up to 3 to 4 weeks. Professor Hayat can comment on it.
Yeah, maybe other seniors could comment on it.
Yeah, so that's why actually we are doing 2 antifungal, okay, and one of them must be amphotericin B. So amphotericin. So this is we are doing in the fungal meningitis. As Sikandar said, is very, very, very rare. But if it has happened, we using 2 antifungal. Sir can talk about it, or Talal.
Yeah, I think we are
No
also
problem.
giving 2 antifungals.
Yeah.
And one of them is liposomal amphotericin.
Yes,
And the second is either fluconazole or cosmofungin.
exactly.
And we use both, either in whether it is just fungal meningitis or invasive candidiasis with evidence of, say, involvement in the eye or heart or kidney ball, renal
Sure.
ball, or lung fungal balls. So whenever it is evidence of invasive candidiasis or invasive fungal infection, and we usually give it as per our ID consultant protocols for 4 to 6 weeks.
Sajjad, you are absolutely right. Meningitis is invasive fungal infection. It's included as considered as an invasive fungal infection, and you should always give 2 antifungals, and the recommended duration is 6 weeks.
Yeah, that's what our understanding is. So in this case, I'm coming back to the comment from about the amphotericin. Then it doesn't matter whether there is amphotericin in the standard amphotericin or the liposomal amphotericin.
That depends if you're using fluconazole with it. If
Yes.
you're only using one antifungal, then it matters which amphotericin you're using.
Yeah, this is exactly the point I wanted to raise. We don't use one, we use 2. Since we use 2, then it's better to use the liposomal, which is much better metabolized as compared to the normal amphotericin.
I think it's like fluconazole has a good penetration into the CSF.
Yes.
Liposomal amphotericin has less, but it has more antifungal action.
Yes, that's correct. And it is much safer as well, as far as the kidney function and other things are concerned.
Correct.
So a few more questions are here. Duration of antibiotic should be calculated from the next culture negative CSF tape or from the first one? So again, sir, I'm repeating the question. Okay, duration of antibiotic should be calculated from the next culture negative CSF tape or from the first one?
We are doing from the first one, 21 days total.
Right, sir.
We do the same as well.
I think Sikandar has answered that question in his presentation. He has suggested that if the baby is improving and is improved in bacterial meningitis, there is no need to do a repeat lumbar puncture. So, so there is no question of doing a second lumbar puncture if the baby is improving. If the baby is not improving, that's a very different question. Then you should be doing it.
Right.
Yeah, I think this issue of the antibiotics or other antifungals after the last negative culture, this is a protocol from the pediatric ID, not from the neonatologists. So if you talk to any pediatric ID for any infection, they start the counting from the last negative culture. And of course, that prolongs the total duration of antibiotic, which we do not support much in the NICU. And as you said, Professor, if the baby is clinically doing very well and is improving, so we usually don't repeat these things. No repeat LPs and you don't even repeat blood cultures.
Right, sir. So here is 2 or 3 more questions. Why we call it as partially treated meningitis?
Because you treat it partially. I mean, simple answer.
Yeah, but in partially treated, there is always evidence of treatment without doing CSF. So somebody has treated with antibiotics by the time you get the patient. So whatever the duration and whatever the type of antibiotic, it has already been treated. So you won't get a result as if you would get in a patient who is first had with you.
Sure.
And of course, the culture is almost always negative. Only you can get the other parameters of CSF which are positive.
Sir, I have to leave to another meeting. I'm sorry. Said, you can continue.
Yes, sir.
And
Yes,
I'll see you all next week. Yeah.
Yes, sir. But sir, one more question is in chat box. 2 more questions. In pediatric patients, we take WBC count more than 5 is suggestive of meningitis, but count is higher in the neonates. So, is there any reason? So, I'm repeating the question. In pediatric patients, we take WBC count more than 5 is suggestive of meningitis, but count is higher in the neonates, as we already discussed, more than 20 or 21. So is there any reason of this cutoff count is more higher in the neonates?
Because count levels are different at different ages. In newborns, the normal values are up to 19 or 20, which is reported in multiple studies.
Right.
And then even in early days of preterm babies, it may be more than 20. But for a cutoff value of 21, we have taken as suggestive of meningitis. So
Right.
newborns have normal values up to 20. So
Right,
whatever it is more than 20 should be taken as a sign of meningitis.
Right, sir. So thank you so much, sir.
The reason for that is physiological, and perhaps all the fellows should go and read some basic physiology, how the white cells enter into the CSF in preterm infants as opposed to a child or a toddler. So that's basically based on physiology rather than anything. I will not give the answer here because I think you should go and read the basic physiology of how white cells enter the CSF.
Right, sir. So thank you so much, sir. I think questions almost are completed. And once again, it was a very wonderful presentation. And thank you so much, sir, for precious time. And thank you so much, Professor Haq and Sir Sajjad Rahman, Sir Talal Rahman, and Sir Junaid Muhib Khan, and all dear colleagues, my seniors and my dear colleagues. So if anybody wants to say something, so
I just want to say thank you to Sikandar. It's a very good presentation. Enjoyed it. Thank you.
Yeah, he has done very well. I really appreciate it. And please put this in the group as well as on the YouTube. It is very basic subject and all fellows would need to go through it again and again.
Ji, sir, inshallah, sir, I will share the link of the YouTube, inshallah, till tomorrow or day after tomorrow, inshallah.
Yes, thank you, Sikandar and Said.
Yes, sir. Thank you so much, sir. Yes, sir. You want to say something?
No, just say Allah Hafiz and take care.
Thank you, sir. Allah Hafiz.
Thank you.
Assalamu alaikum.
Alaikum.